Hello, good morning to all the guest speakers and to all participants attending online. On behalf of the committee, I'm Stella. I'm very pleased to welcome you all to the World Class University program sharing experience in skin cancer management, held by Dermatovenerology Department, 11 Maret University. Just before we start, let's praise and thank God that we are all gathered here today in good conditions, even though we're still in pandemic era. Without further ado, allow me to deliver the rundown of this event. First is the opening and remark from the head of Dermatovenerology Department, Dr. Muhammad Eko Irawanto, dermatovenerologist. And then we will continue to the main agenda, that is sharing experience in skin cancer management. There will be 3 sessions of lectures followed by discussion. In these sessions, participants is allowed to ask to all of the speakers by typing it down on the Q&A section. After the discussion sessions, there will be a lucky draw for free registrations door prize to our upcoming event that will be held on the 5th November 2021. Continuing Medical Education's New Approach in Nail Disorders. Now, allow me to start with the first agenda, that is the welcoming speech from Dr. Muhammad Eko Irawanto, dermatovenerologist, the head of Dermatovenerology Department, 11 Maret University. To Dr. Muhammad Eko Irawanto, dermatovenerologist, the time is yours.
Good morning, everybody. I am Dr. Muhammad Eko Irawanto, the head Dermatovenerology Department of Umati General Hospital, Surakarta. First of all, allow me to thank to Professor Jamal Wiwoho, Director of 11 Maret University, for giving us the opportunity to run the World Class University program. And also to Dr. Cahyono Hadi as the director of Dr. Muwardi General Hospital to facilitate this event. I would also like to thank Yasuhiro Fujisawa MD PhD from University of Tsukuba, Japan, for your kindness sharing your experience and knowledge to all of us here. Last but not least, thank you to all the participants. I hope this event will improve knowledge to your daily practice. Please enjoy this event. Thank you. Arigato gozaimasu. Matur nuwun.
Thank you, Dr. Muhammad Eko Irawanto, dermatovenerologist. It is now time for the main agenda that will be led by Atniana Naraswari, dermatovenerologist. Please, Atniana Naraswari, dermatovenerologist, you may take your time.
Well, thank you very much, Dr. Stella, for the time given to me. And from now on, I will lead and also moderate this webinar. But firstly, I want to say hello to everyone here. Good morning for all of the speakers. Good morning and thank you very much for all of the participants, professor, doctor, resident, college, and all of the audience joining in this webinar. And well, today we'll have 3 speakers here. The first is Sensei Yasuhiro Fujisawa, MD, PhD. He is going to share his work on the melanoma diagnosis and management in Japan. The second speaker is Dr. Amaryllis Murastami, dermatovenerologist. She's going to talk about the tumescent anesthesia for facial tumor surgery. And our last speaker is Dr. Nugrohaji Darmawan, Master of Health, dermatovenerologist consultant, with the topic entitled Basalium flap in different facial area. Well, our first speaker, Sensei Fujisawa, today will share his countless experience in diagnosing and also treating melanoma, especially in Japan. Well, before we start the presentation, allow me to review a brief profile of him. Sensei Yasuhiro Fujisawa was born in Kanagawa, Japan, 3rd April 1973. Right now, he is an associate professor at Department of Dermatology, Faculty of Medicine, University of Tsukuba, Japan. And he is a member of several organizations and associations like the Counselor of Japanese Skin Cancer Society, board member of Skin Cancer Epidemiology of Japanese Skin Cancer Society, and also a core member of Dermatology Unit of Japanese Clinical Oncology Group. And he has been awarded many times for his work in dermatology, both in Japan itself and abroad. And his current work achieved academic award by the Ibaraki Medical Association in 2018. He has published a lot of journals and articles, especially on dermato-oncology school. Well, today Sensei Fujisawa would like to share his lot of experience in diagnosing and in treating melanoma, especially in Japan patient. And surely this is a very great opportunity for us here in Indonesia to learn more from him and to know more how other institutions abroad manage the melanoma case. So please, audience, listen carefully and be focused to what Sensei present. And please, Sensei, time is yours.
Maybe someone in the audience know him. He was the head of dermatology division of Toranomon Hospital. He visited in times and teaching how to manage skin. I will go with him time after this pandemic ends, so please welcome me if you remember me. I'd like to talk about these three topics: epidemiology, diagnosis, and the treatment of melanoma in Japan. I think the situation in Indonesia and Japan, the incidence of melanoma in Japan much lower when compared with Caucasians. It's about 50 times lower than United States. So in Japan, melanoma is considered as a rare tumor. Melanoma can develop everywhere in our body and classified according to their clinical features, such as lentigo maligna, superficial spreading, nodular, acral, and mucosal, and also uveal. Uveal is very rare, and we do not manage this type. So today, I would like to focus on these types. The frequency of each clinical type differ between. In Japan, acral and mucosal consist more than half of all melanomas, but less than 5% in United States, and instead, more than 90% consisted by cutaneous melanomas. This imbalance makes very big difference when we consider treatment. First, BRAF mutation frequency also differ between clinical types. As you can see here, the acral and mucosal melanoma have only 1 in 14 patients, whereas nearly half of the cutaneous melanoma have BRAF mutation. This means Asian melanoma patients have less chance of using BRAF MEK inhibitors. Not only BRAF mutation, as shown in this famous article, DNA mutation frequency differs significantly between clinical types. Melanoma is known to have high DNA mutation frequency, but almost zero among the acral and mucosal melanomas. So the DNA mutation burden differs between clinical types. This is also a famous article, and you may have probably seen this figure. The x-axis shows the tumor DNA mutation frequency, and the y shows the response rate to PD-1 therapy. It is clear that the PD-1 response correlates with tumor mutation burden. As I have shown in the previous slide, frequency of DNA mutation differ between clinical types. So here comes the question. It's the same melanoma, but does the response to PD-1 differ between clinical types? We analyzed patients treated with PD-1 or chemotherapy at our institute and compared the survival. As a result, you can see here, right-hand panel, the acral melanoma with PD-1, this red line, showed better survival than treated with chemotherapy, this black line. But the efficacy of PD-1 among superficial spreading type, this middle panel, was much higher than acral melanomas. So, as we expected, acral melanomas, which have less tumor mutational burden, were less sensitive to PD-1 compared with superficial type. This is a poster presentation at ASCO this year showing that the acral melanoma was less sensitive to checkpoint therapy in Netherlands registry data. Both response rate and the survival were as low as half of the less than half of the melanoma. So melanoma is now considered as a PD-1 resistant tumor worldwide. This is a brief summary of this part. More than half of melanoma in Japan is consisted by acral and mucosal, whereas less than 5% among Caucasians. Acral and mucosal have less DNA mutation, including BRAF. This makes us difficult to treat because less chance of using BRAF inhibitor, and moreover, less sensitive to PD-1 therapy. In other words, Asian melanomas are tough to treat than Caucasian melanomas, which mostly included in the clinical trials. Next, diagnosis. I think you all agree these melanomas show typical appearance and diagnose cake. But how about these cases? Half of them are non-melanoma. Can you diagnose which one is non-melanoma? The answer is this. These are non-melanomas. Sometimes other tumor mimics melanoma and difficult to rule out. This can lead us overdiagnosis, but I don't think this is a problem. But how about these cases? Half of the cases in this figure, non-melanomas. Can you diagnose precisely which one is melanoma only by this clinical information? The answer is, these are melanomas. The amelanotic melanoma sometimes do not look like melanoma. I think this case problem since we can easily overlook. We usually use ABCD rule and dermoscopy for screening, but the final diagnosis should be made by excision. We routinely perform excision, and we do not recommend partial excision since it would be difficult to determine the tumor thickness. This is the flow of our institute. We start from excisional biopsy, and when the tumor is in situ or T1A, we offer local excision only. And if the tumor is shown to have more than T1B, we do CT or the PET scan. The patient with distant metastases, no radical surgery offered. No distant metastases, but with lymphadenopathy, the patient will receive local excision plus lymph node dissection. Patients without lymphadenopathy, we offer sentinel lymph node biopsy. But we do not offer lymph node dissection even when the patient found to have sentinel lymph node metastases. Rather, we offer adjuvant therapy. When the tumor locally advanced and confident with the diagnosis like these cases, I skip excision and start from the CT or the PET scan. The brief summary of diagnosis to staging. I prefer excision in all cases except advanced piece of cake tumor. And we offer sentinel lymph node biopsy when the tumor T1B or more. But we do not offer lymph node dissection even in cases with sentinel lymph node positive. What I think most important is not to hesitate excision. Overdiagnosis is just fine, but not good if we overlook melanoma. The last section, the treatment. We had before 2011 was surgery. No effective chemotherapy and the melanoma is radio-resistant. So we tried radical surgery for patients with local regional advanced cases. However, according to my experience, radical surgery did not bring good result to patients. This is the NCCN guideline when I became medical doctor in 1998. Since no effective chemotherapy exists, the most recommended treatment for advanced melanoma was clinical trial. This recommendation kept until 2012. However, since 2011, immune checkpoint inhibitors and BRAF inhibitors became available, and these drugs completely changed the treatment of advanced melanomas. This is a case treated using PD-1, locally advanced mucosal melanoma, and he refused surgery. 3 months after the treatment started, almost completely disappeared. This is a case of multiple metastases treated with dabrafenib and trametinib. You can see the multiple metastases with pleural effusion, and she could not walk when she transferred to our hospital. We assumed she would die within a month. But 4 months after we started dabrafenib and trametinib, she achieved complete response and still in good condition. This is a result of pivotal clinical trials. The 3-year survival of dacarbazine was as low as 15%, but the ipilimumab achieved 30% and PD-1 50%, combo 60%, and BRAF/MEK inhibitor achieved 50%. So, according to these clinical trials, survival of advanced melanoma improved dramatically. However, we should be cautious when interpreting these due to the following reasons. First, only the good patients will enroll in the trial, so there is the enrollment bias. Second, we should consider racial difference. As for melanoma, clinical type differ between races, and clinical type directly connected to DNA mutation status. As I have shown in the previous section, acromelanoma do not respond to PD-1 as good as cutaneous melanomas. But how about the BRAF/MEK inhibitors? To clear this question, we conducted multi-center retrospective study. You can see details in the European Journal of Cancer published early in this year. We collected 112 cases, and among this cohort, the response rate was 75%, And surprisingly, patients already treated by another therapy also achieved similar response. As for the acral and mucosal melanomas, which clinical type we interested in, showed slightly lower similar response. So we could not see clear difference between clinical types by means of response rate. As for the progression-free survival and overall survival, acral and mucosal melanoma, this red line, was completely the same as the cutaneous melanomas, this blue line. So no correlation between clinical type and survival was seen in our study. So the bottom line, BRAF inhibitors might be effective irrespective of clinical type. So now I can say that the evidence brought by the clinical trials using BRAF inhibitors conducted in the Western countries can directly be transferred to Asian patients. But please be careful of brain metastasis during this BRAF therapy. We observed 18% of brain metastasis in our study. I have never heard of this high frequency, so I closely looked into the previous clinical trials. As a result, I found the frequency of brain metastasis in the famous COMBI-D and COMBI-V trials. In that trials, the brain metastasis occurred exactly the same frequency as in our trial, 18%. So I believe the high frequency of brain metastasis during this BRAF/MEK inhibitor common phenomenon. So I prefer periodical brain MRI when you treat patients using BRAF/MEK inhibitors. This is a treatment strategy for advanced cases. For BRAF wild-type tumor, we have only checkpoint blockade, and the second line would be the traditional chemotherapy. As for the BRAF mutant patient, I prefer using BRAF/MEK inhibitor, since we know this drug will similarly effective among Asian melanomas. Immune checkpoint blockade comes after BRAF/MEK. And we try BRAF/MEK again when checkpoint failed. After that, we will try conventional chemotherapy. Left panel, red line indicates the survival curve of stage 4 patients treated with new drugs, and the blue line shows the conventional chemotherapy. It is clear that the red line, the right panel, this is the annual number of melanoma deaths. As you can see, melanoma death increased year by year until 2014. 2014 was the year the Japanese authority approved nivolumab and bemrafenib. After 2014, number of deaths become the survival of advanced melanoma in Japan. As for the adjuvant therapy, many new drugs proved to be effective by clinical trials. In Japan, all but except ipilimumab approved to use as adjuvant since 2018. This figure shows the efficacy of adjuvant therapy in the clinical trials. Roughly, PD-1 and BRAF/MEK inhibitors reduced 40 to 50% of relapse risks in stage 3 melanoma patients. So currently, adjuvant therapy is a standard of care and almost everyone received in Japan. However, as I shown in your slide, we should consider ratio difference because PD-1 is less effective for Asian melanoma in the advanced setting. We need to confirm the effect of PD-1 as an adjuvant setting in Asian population. Also, we need to consider cost of adjuvant therapy. Red line is a relapse-free survival of patients who received adjuvant, and blue line, no adjuvant. These patients cured only with surgery, so these patients do not need adjuvant therapy. On the other hand, these patients relapsed in spite of receiving adjuvant. So we need to treat at least 5 patients to avoid one relapse, meaning we have to pay 50,000 US dollars to avoid one relapse. In other words, 4 out of 5 patients received unnecessary adjuvant treatment. So we definitely need biomarker to find who requires this treatment. This is the final slide. Many new drugs are now available for advanced melanomas. We now know that these new therapies began to improve melanoma prognosis in Japan. But we should know that the melanoma among Asians differ from that of Caucasians. Acral and mucosal melanoma are now known to be resistant to PD-1. But on the other hand, BRAF MEK inhibitors similarly effective as the clinical trials. Cases, we not yet fully understand the real-world effect of adjuvant setting in acral and mucosal melanomas. So we should conduct clinical trial or clinical study to confirm the effect of PD-1 among Asian melanomas. So we need evidence made in Asia. Thank you for your attention.
Thank you very much for your such a great presentation today. And for the speakers, you can type down your question on the Q&A box, and we will discuss it later on Q&A discussion. And now we move to our second speaker, Dr. Amarilis Murastami, dermatophenologist, with the topic entitled Tumescent Anesthesia for Facial Tumor Surgery. And this is the profile of her. Dr. Amarilis Murastami, dermatophenologist, was born in Surakarta, 11th November 1980. She is a lecturer in dermatophenology department of 11 Maret University and also staff of UNS Hospital. And she is in charge in the dermato-oncology surgery division. Dr. Amarilis is active in several associations like Indonesian Society of Dermatology and Venereology and also Indonesian Dermatosurgery and Oncology Study Group. She is active in joining seminars and workshops in Indonesia as well as abroad. And please, Dr. Rama, time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning to all participants. Hope all in a good condition. Thank you for having me today in Webinar Plus University. I'm Dr. Amarilis. Today I will share about tumescent anesthesia for facial tumor surgery. The tumescent anesthesia originally developed to facilitate the liposuction, and the use of tumescent anesthesia nowadays has expanded to other dermatologic and plastic surgery procedures, as well as to other disciplines, including endocrine and vascular surgery. Tumescent anesthesia is an infiltration technique of large volume of tumescent solution administered in subcutaneous area, and it causes swelling and firm consistency. It produces anesthesia in large area of the skin and subcutaneous tissue. Tumescent anesthesia is performed in awake condition so that we can ask the patient to be cooperate with the surgeon during the procedures. Tumescent anesthesia was first introduced by the dermatologist Dr. Klein in 1987. It contains local anesthetic such as lidocaine epinephrine for potent vasoconstrictor, and sodium bicarbonate mixed in normal saline. Addition of sodium bicarbonate will increase pH solution and reduce pain during the infiltration. It reduces blood loss and post-operative bruisings, and it provides excellent analgesia for about 18 until 24 hours. So, if your procedure is involve large area or have multiple lesions, need prolonged duration or anesthesia, or we have do multiple punctures that we think would be painful, and hence single or minimal number of entries, you can use by the tumescent technique. In dermatologic surgery, we can use tumescent anesthesia for example, hair transplantation, skin biopsies, cosmetic surgeries such as laser resurfacing, dermabrasion, subcision for acne scarring, facelift, blepharoplasty, microneedle radiofrequencies, and also we can do for various surgeries. These are the advantages of tumescent anesthesia. First, outpatient administration, have prolonged anesthesia, profound hemostasis, reducing the blood loss by vasoconstriction, extended post-operative analgesia, reduced post-operative pain, minimal downtime, and absence of need for hospitalization. The safety of tumescent anesthesia depends on lidocaine metabolism and elimination. Lidocaine is metabolized in liver and excreted in kidney. Therefore, we must be aware of drug interaction. Toxicity of tumescent anesthesia in the dose of 3 until 6 microgram per milliliter, it can cause lightheadedness, nausea, and drowsiness. In 7 until 10 microgram per milliliter, it can cause tinnitus, circumaural numbness, or muscle fasciculation. Above that, it can lead to seizures, coma, respiratory, and cardiac arrest. These are tumescent anesthesia dose, as we all know well. We usually use this formula for liposuction. We can use clean solution, consists of 0.05% of lidocaine concentration, or Lilly solution or double strength of clean consists of 0.1% lidocaine concentration. For the note, the maximal dose for liposuction is 55 milligram per kilogram body weight with epinephrine. And for non-liposuction, we convert the dose to the total of tumescent anesthesia as needed. For non-liposuction procedures, here are some examples of formulas that we can use. First, example for 0.5% lidocaine. We need in 1,000 formula, we need 4,000 milligram of lidocaine in 1,000 milliliter of normal saline. If we use 100 milliliter formula, we have or we need 400 milligram of lidocaine in 100 milliliter of normal saline. And if we use in 10 milliliter formula, we need 40 milligram or 1 ampoule of 2% lidocaine in 10 milliliter of normal saline. These are examples for concentration 0.2% of lidocaine or cold field formula. It consists This an example of 0.2% of lidocaine formula called field formula. We need 1,000 milligram of lidocaine in 500 milliliter of normal saline. We can use the simple tumescent formula with standard mix of lidocaine and epinephrine, or in the market we call PH-caine. We can put 2 milliliter of PH-caine and add it with 8 milliliter of normal saline. This is equal to 0.5% of lidocaine. This is recommendation dose of tumescent anesthesia from claim. As we see in the face area, chin, cheek, and jaws, we can use 0.2% of lidocaine concentration in 1,000 milliliter of normal saline. For the note, the maximal dose for non-liposuction procedures is 28 milligram per kilogram body weight. The tumescent anesthesia in face, we use usually 300 until 400 cc of anesthetic solution, and the final concentration would be 0.08% of lidocaine. We see salah. Ulang yang slide 15.
Iya, dokter. Slide 15.
Ini tuh kursornya harus digerakin gini-gini. Itu nggak bisa ya? Nanti pakai.
Nanti pointer.
Oh,
kalau
okay,
dokter mau menjelaskan ini nanti tunjukkan ke Aji aja dok. Nanti Aji akan tampil kursor pada editor.
Oh gitu.
Yang
Jadi kan
mana,
kayak pas ini insertion site of forehead, temporal area ini
yeah.
In mid anterior hairline.
Siap,
Nih.
di situ ya dok.
Would be 0.08% of lidocaine. We do the insertion site of forehead, temporal area, medial nose. We can inject the solution from mid-anterior hairline. For the lateral nose, chin, lips, we can inject the solution from lobule cheek. And for the chin and area under the nose, we can inject the solution in lateral lips. The technique of tumescent anesthesia, first, do infiltration about 2 cm feathering. After swelling and already under anesthesia, we wait until maximal diffusion in about 15 until 30 minutes. And lastly, wait for more than about 10 minutes in sensitive areas before initiating the procedures. This is an example of the case of basal cell carcinoma near the nose. This is our experience of performing tumescent. We use the tumescent dose of 125 milliliter normal saline, consists of 7 milliliter of silocaine. For take-home message, first, concurrent use with drug which metabolize in cytochrome P450, such as cimetidine, beta blocker, and anxiolytic drug must be aware. Focus history and physical examination to determine presence of hepatic or renal disease. Obtain a thorough medication history. Calculate the maximum allowable dose of local anesthetic in milligram. Calculate maximum allowable volume of dilute local anesthetic concentration for infiltration. It is important to understand that although tumescent anesthesia's process may appear simple and easy, complex pharmacological and anatomical considerations are necessary. Practicing dermatologists should be specifically learn the technique in the hand of trained surgeon before using this technique. It is important to understand that the process takes time, cannot be hurried, and patient comfort and safety are the utmost consideration. So that's all my presentation. Hope will be beneficial to all of you. Thank you. Arigato. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Amarilis, for your sharing on the tumescent anesthesia, an anesthesia that commonly used, especially in dermatosurgery procedure. And now it's time for the last topic today, entitled Basalioma flap in different facial area, which will be presented by Dr. Nugraha Darmawan, Master of Health, Dermatophenologist Consultant. Dr. Nugraha Darmawan was born in Surakarta, 30th October 1975, and right now he is the head of Dermatophenology Department of 11 Maret University, and also as a dermatophenology surgeon in Dr. Muwardi Hospital. He is also a vice president of Indonesian Dermatosurgery and Oncology Study Group, and also a member of Indonesian Society of Dermatology and Venereology. Dr. Nugraha is a national and international speaker for various seminars and also workshops. He has published some papers in reputed journal. And please, Dr. Nugraha, time is yours.
Okay, good morning all the attendants. Thank you for having me in World Class Webinar University. And today I would like to present basalioma or basal cell carcinoma flap in different areas in my experience since 2008. Flap is different from graft. Flap transfers skin tissue from the donor to recipient by maintaining the blood supply, while graft transfer autologous tissue to the recipient side, and it depends on blood supply of recipient side. We also know primary tissue movement and secondary tissue movement. Primary tissue movement is shifting to the skin flap to close the defect by sliding or pivotal movement. And secondary tissue movement is shifting on the skin tissue around the defect toward primary defect or secondary defect, and it is achieved by undermining. In facial area, we know facial aesthetic regional and facial aesthetic units. Facial area is divided by many regions such as forehead, nasal, upper lips, lower lips, mandibular, zygomatic, and etc. While cosmetic unit like on nasal, such as alar lobule, tip, dorsum, and lateral sidewall. Flap can be classified into several types based on method of transfer, for example, pivotal, advancement, and hinge. Pivotal type comprises rotation, transposition, interpolated, and island, while the advancement type include unipedicle, bipedicle, V to Y, Y to V, and island flap. Now, I will show you several types of flap usually performed, especially for BCC, which is common in our hospital. The first is pivotal flap. It is divided into rotation, transposition, interpolated, and island. All pivotal flap are transfer of flap to defect by pivoting the flap around the fixed point at the base of the pedicle. The key point of pivotal flap is the greater the pivotal of the flap, the larger the deformity occurs. So the possibility of dog ear is greater. First is rotation flap. Pivotal flap is the best used to close triangular defect. We have to make sure the ratio of the length of the incision to width of the defect is 4/1. So bursting triangle is usually not necessary. Rotation flap is beneficial as it is simple, good vascularity and flexibility. The second is transposition flap. Transposition flaps are transposed from one area to another, usually over the intervening segment of the normal tissue. There are two types of transposition flaps. First is rhomboid flap and the second is pillow flap. Rhomboid flap comprises two triangles with the angles of 60 and 120 degrees. However, it has disadvantage because it is not parallel to relaxed skin tension lines or RSTL. Pillow flap, it is double transposition flaps for repairing a nasal tip defect. This disadvantage, it is not parallel to RSTLs. The interpolated flap, it is similar to transposition flap, but the base of the flap is far from the defect. So it needs second operation to cut the flap. Slide 15. Island flap is the flap with total incision, but it still has supply blood from the base of the flap. The advancement flap is linear configuration and are moved by sliding toward the defect. The advancement flap is usually used for area which has greater skin elasticity. The advancement flap comprises unipedicle, bipedicle, V2Y, Y2V, and island flap. The unipedicle advancement flap is parallel incision by sliding the flap to close the defect with single factor toward the defect. We usually say euplasty. The common procedure of the bilateral unipedicle advancement flaps are H-plasty and T-plasty. There are two types of T-plasty, O2T-plasty and A2T-plasty, which is used to repair skin defects of the lips. This is V to Y and Y to V advancement flaps. This is our cases. This is O2C plasty procedure that we perform in a 70-year-old female with BCC on her forehead area. In this patient, we chose these techniques because the skin of the patient is relatively loose. And another reason is because the incision line is parallel to RSTL. And this is patient with BCC on the temporal area with a diameter of 1 centimeter. In this case, we use V to Y for this patient because the size of the tumor is relatively small and the incision line is parallel to RSTL. And this is H-plasty technique that performed on 65-year-old female with BCC on frontal area. We choose these techniques because we have to disperse skin tension because the tumor is relatively large. It is about 4 times 4 centimeters. Another reason is because the incision line is parallel to RSTL. And this is transposition flap techniques performed on 62-year-old female with BCC on temporal area. We use transposition flap for this patient. And this is double rhomboid flap performed on the nasal. This is the most interesting technique that I ever done because usually the flap is taken from the forehead area or from malolabial area. But in this case, we just close the defect from the local area using double rhomboid flap, and the result is very good. You can see here this picture, especially picture number 4. Okay, this is a 70 years old woman with PCC on her nasal dorsum. We perform dorsal nasal flap, which is one of the pivotal flap techniques. We close the defect using glabellar skin, and the tumor site is similar to the previous case, but we use different techniques. And both techniques give a good result. This is interpolated malolabial flap on 72 years old man with PCC lesion on his nasal area. We use interpolated malolabial flap, and we need second operation to cut the base of the flap after the skin that closed the defect is viable. And this is malolabial advancement flap on 69 years old patient with PCC. We perform advancement flap because this techniques is parallel to RSTL. Another reason is the malolabial advancement flap is relatively large, so the success of the skin flap is great and the outcome is good. This is otoziplasty on 65 years old male with PCC on the upper lips. We use this technique because we want to keep the philtrum, and the result is very good. Here is also my exciting case. I perform advancement flap on 65 years old woman patient with PCC on the upper lips. And because the lesion is really large and deep, so we have to cut the tumor, including the muscle. We perform double advancement flap from the left and the right of malolabial area, and the result is very outstanding. We can maximize the result without losing its function. This one, my newest case on 73 years old female with PCC on the right alar lobule. We close the defect after wide excision of the tumor with skin flap from malolabial area to cover alar lobule, and we need second operation to cut the base of the flap after a week. This patient still regularly visit to my hospital. Well, that's all I can say about flaps, and we have to keep in our mind that we must. The first is improve our case reference is very important. And the second, we have to always plan and map before the procedure. The third, we can use tumescent anesthesia, and don't forget to undermine of the surrounding skin defect. Next, good suturing techniques will result in a good cosmetic, and we have to remember no single best techniques because each operator have different projection of the flap. And the last but not least, always have a courage to practice and try. Okay, thank you for your attention, and I hope what I share with you all will give good benefit for all of us. Thank you and see you. Arigato gozaimasu.
Have 15 minutes here. Okay, I will come back to all of the speakers.
Mm. Okay, welcome back to all of the speakers. Good morning, Sensei Fujisawa. How are you today? Hope well, and please stay safe and healthy there. We're really glad to have you here with us today. And good morning also to Dr. Amarilis. Anyway, I would like to inform you all, in this session we will have discussed in either English and Bahasa. So please, for all of the audience who have questions for the speakers, please type down your question in the Q&A box. And well, now we'll move to the audience question, which already seen on my Q&A box. There are already here for you. And the first question comes from Lola Novira Rizbianti. Good morning, Sensei. Can cancer be completely cured or only after surgery is? Maybe this question for Sensei Fujisawa, please, Sensei.
Yes. The what do you say? The main treatment of melanoma is surgery. So if the patient can be resected, you should do surgery first. And if the patient having a residual tumor which is unresectable, and then we should think of the what do you say? The chemo, not the chemo, but immune checkpoint inhibitors or BRAF inhibitors. So the surgery is the best.
Okay. So the first surgery first for especially
Yes.
for early stage of
Yes.
melanoma, then we can combine it with systemic therapy like that, chemotherapy or immune therapy, targeted therapy, and etc. Thank you, Sensei. And move to the next question from Dr. Caroline Octarina to Sensei Fujisawa. She has two questions for you. The first is, you suggest periodical MRI during the BRAF or MEKI treatment. How and how often should the MRI be performed?
Yes.
And the second question is, as the response BRAF or MEKI treatment is higher as second-line therapy, do you suggest administering it as first-line treatment or second-line treatment?
Thank you for the question. As for the first question, how often we should check by MRI. I don't know the situation in Indonesia, but in Japan, it's not so easy to get space to take MRI. So I do maybe once in 6 months, and do it 6 months later. So twice in a year. This is the maximum. I don't prefer doing every month or every 3 months. So I prefer every 6 months. And the sequence of using the immune checkpoint inhibitors of the BRAF MEK, well, it's quite difficult question. And as I've shown in the presentation, the immune checkpoint inhibitors do not act same as in the clinical trial in Japanese cases. So it's completely my opinion. If the patient having a BRAF mutation, I use BRAF MEK first because I want to be a good doctor. More than 70% of patients can achieve some kind of response. So I want to be a good doctor, so I will choose a BRAF MEK inhibitor first.
Well, okay, thank you, Sensei, for your answer. And move to the next question from Dr. Teddy Sutrisna. Prof, which one the best biologic agent for melanoma treatment?
Yes, thank you. By means of biologic, maybe she's that doctor asking about the which PD-1 or the ipilimumab CTLA-4 combo. I think the best is the combo nivo plus that's the best. It's about response rate of 50%. And the therapy, it's about 30 to 40%. So the best is Nivo-EP. But according to my experience, most of the patients develop the grade 3 or 4 severe adverse events. So if the patient is 80 years old, 90 years old, I don't offer the Nivo-EP. If the patient is young and understand the advanced events, I offer the Nivo-EP. So the Nivo-EP combo is the best, I think. But we should be cautious about the adverse events.
Well, so actually still the best is the combination therapy.
Yes, I think so.
Okay, next question. Sorry. Can read the question. Well, this question come from the anonymous attendee. Sensei, based on your experience, which kind of lesion would be eligible for most surgery option?
Sorry, I can get your question.
Which kind of lesion of melanoma would be eligible? Which kind of lesion? Which kind of lesion? Melanoma lesion. Which kind of melanoma lesion that would be eligible for most surgery?
Most surgery.
I mean
most surgery.
Yes.
I'm sorry. In Japan, we can't do the most surgery because the pathologists in Japan do not do most surgery. So we do not. I have no experience of using most surgery. So we do excision by determining the margin by our eye only.
Okay, so in Japan there's no most surgery and we just do the wide excision directly to the lesion.
Yes.
Okay. Okay, the next question for Dr. Nugroho Haji, mungkin dalam bahasa Cedok, saya lanjutkan diskusi dalam bahasa. Bagaimana pertimbangan pemilihan garis insisi dan flap untuk nevus melanocytic benign yang lokasinya tepat di cupid bow dengan diameter 1,5 cm. Terima kasih, dokter.
Okay, terima kasih Dr. Agni. I'm sorry since I speak in Indonesia because the question is in Indonesian language. Untuk memilih lesi yang ada di filtrum sebenarnya di daerah perbatasan bibir, sebenarnya kita menggunakan teknik atutiplasti ya. Yang biasa kita gunakan adalah atutiplasti. Tapi lesi-lesi yang kalau dari sini dari cupid ya, tanyanya di cupid. Cupid area berarti di tengah-tengah bibir pas. Kita harus lihat kalau 1,5 cm itu besar sekali. Mau nggak mau sebenarnya kita berusaha mempertahankan filtrumnya. Tapi kalau memang tidak bisa secara kosmetik, enggak, itu pertimbangan kedua. Yang pertimbangan pertama adalah kita harus bebas tumor dulu, apapun hasilnya. Kalau memang itu luas, kita bisa flap, kita flap. Tapi kalau tidak bisa di flap, kita bisa usahakan dengan graft. Tetapi biasanya untuk daerah perbatasan bibir yang paling cocok digunakan adalah atutiplasti. Kira-kira begitu, Dr. Ato. Thank you.
Oke, thank you. Terima kasih Dr. Nugroho Haji atas jawabannya. Kemudian saya akan melanjutkan untuk pertanyaan selanjutnya. And maybe this question is for you, Sensei. Again, good morning, dear Professor Yasuhiro Fujisawa. I'd like to ask about what is the prevalence of pigmentation in patients with malignant melanoma, and how does it affect the treatment selection?
Thank you. As I presented in my presentation, the BRAF mutation, what is the frequency, quite differ between the clinical types. So if the young patient came with melanoma on the trunk or some kind of like that, we expect that patient having a BRAF mutation. But what is the elderly patient with melanoma in the hand or the foot, the percentage of BRAF mutation is about 7% or so. So you can predict the BRAF mutation status by looking into the clinical types. So more than 50% of the superficial spreading type having a BRAF mutation, but the mucosal and the acral type have less than 10%. So every time we see the advanced melanomas, we routinely check the BRAF mutation status so that we can choose BRAF or the immune checkpoint inhibitors.
Sensei, thank you for your, I think that's so clear. And next question for Dr. Nugroho Haji. What is the best suturing techniques for Z-plasty and bioloflap? Since I think about this complex flap shape, I think. For the best suturing technique for this flap, this kind of flap.
Okay, thank you, Dr. Agni. In my experience, I always use psychosurgery techniques in my own vision because it's okay. Because the psychosurgery techniques is easily to control the defect after patient control to our department. Because we can remove all the suture by on the flap. So single suturing technique is I think is better than continuous suturing technique. I think so.
Oh, thank you, Dr. Nugroho Haji. And I think this one is the last question for today because it's almost the end of this discussion. And the last question, again, for you, Sensei Fujisawa,
Yes.
from Dr. Larissa from Cipta Mangunkusumo Hospital, Jakarta. Much appreciate for the great lecture, Sensei. And the question is, your institution do not recommend to perform sentinel lymph nodes dissection for late-stage melanoma, even though it's detected by the SLNB. Why so?
Oh, thank you for the question. If we see the apparent metastasis, the patient having a lymph adenopathy, we perform a lymph node dissection. But the patients who do not having a lymph adenopathy, but positive, found to be positive by the sentinel lymph node biopsy, we did a lymph node dissection maybe 3 or 4 years ago. But after the MSLT2 trial confirmed that the sentinel lymph node biopsy positive patient who undergo lymph node dissection or just the follow-up did not change at all by means of survival. So in the Western countries, almost all the institutes stopped doing a lymph node dissection for patients having a sentinel lymph node positive. So we just follow that study result.
Well, maybe Dr. Nugroho Haji have a question for Sensei Fujisawa, or Dr. Amarilis have a comment or a question for Sensei.
Okay, thank you, Dr. Adni. How are you, Sensei?
Good morning.
Good morning. This is my first time to meet you. Okay, I hope you always healthy. And I want to ask about one question for you, Sensei.
Yes.
Yeah. You said that in your department,
Mhm.
for BCC surgery, you never you do perform post surgery with confirmation of histopathological.
Mhm.
What is the uh, result of your patient with BCC case without the histopathological confirmation?
Oh,
In my department, I always perform
mhm.
confirmation before we close the defect. Thank you, Prof.
Okay. Maybe my explanation was bad. In Japan, we cannot do mold surgery, so we don't do molds.
Yeah.
So if the margin if we are not confident with the surgical margin, we don't close at that day. We just leave it open, and after we confirm the pathologically free, then next we will consider the reconstruction. Maybe we can use intraoperative but it will take 1.5 hours. We have to wait until the results come. We can't take so long time for the local anesthesia. So if we want to use the intraoperative frozen section control, we have to do it under the general anesthesia. So most of the BCCs we do under local anesthesia. So if we are confident with the margin, we just primarily close. Now after operation, we confirm the histopathology. But if we are not confident, we just leave it open.
Okay. Okay, thanks. Thank you, Sensei.
Thank you.
Thank you.
Well, there's so many questions. Because of our limited time, I think this is the last question. One more Sensei.
Yes.
A question from Dr. Prastyadi Mawati. If our melanoma patient have a BRAF genetic mutation or other mutation, which option we can plan to manage the condition? Targeted or immune therapy option? Thank you. Patient with BRAF genetic mutation.
Yes.
What's the best?
If that patient is my patient, I will prefer BRAF and MEK inhibitors because, as I have told you, the response rate of BRAF MEK inhibitors can achieve nearly 70 to 80%. But checkpoint inhibitors may be around 30, 40. So if you need rapid response, maybe there's no other choice than the BRAF MEK. But if that patient have very low tumor mass, and if you can wait, maybe you can choose immune checkpoint inhibitors. So I prefer BRAF MEK for if that patient is mine, but it depends on the patient condition, I think.
So it's your preference still the BRAF
yes.
for the therapy. Okay. Well, this discussion today. Thank you very much for your awesome experience sharing, and thank you for all of the participants who have followed the discussion until it finished. And especially thank you very much, Sensei Fujisawa. We're really happy to have you here. It's so honor and a pleasure for us here to meet you, and me personally really happy to meet you virtually, and I hope we can see in the real soon to discuss more about this melanoma or other dermatology issues. Okay, and I think this is all of, for the discussion. And now I will hand it over to a Master of Ceremony. Thank you and goodbye.
Thank you, Prof. Thank you.
Thank you, Dr. Adni. I also would like to thank all the audience participating in this event. Please remain online as I'm going to announce the 10 lucky audience who won the free registrations to our upcoming event, Continuing Medical Education, New Approach in Nail Disorders. Well, the interesting event comes to an end. I would like to say thank you to the guest speakers and to all of you participants, especially Sensei Yasuhiro Fujisawa, MD PhD, and University of Tsukuba, for sharing their very useful and applicable knowledge to all of us. Thank you very much and see you on the next event. Goodbye, sayonara, sampai jumpa.
Selamat pagi. Kita akan memulai pengacakan nama penerima door prize pada hari ini. Pada kesempatan kali ini kita akan untuk yang kita akan bayar ini akan akan kita mulai ya, 1, 2, 3. Stop. Ya, ini adalah 10 nama partisipan yang memenangkan door prize pada hari ini. Oh, 5 partisipan door prize pada hari ini. Selamat kepada 5 audiens yang memenangkan door prize pada hari ini. Kita akan menghubungi para partisipan melalui email. Dimohon untuk menunggu kabar dari panitia. Terima kasih.
Penerima baru. Penerima kedua. Penerima kedua. 5 kedua.
Ya, kita akan mengundi lagi untuk 5 partisipan berikutnya. Bisa dimulai, 1, 2, 3. Stop. Ya, ini adalah 5 partisipan kedua yang memenangkan door prize pada hari ini. Selamat kepada 5 partisipan tersebut dan kami akan menghubungi audiens yang memenangkan door prize pada hari ini melalui email. Untuk partisipasinya kami ucapkan terima kasih.